Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of our speakers' presentations, we will open the floor for questions. I would now like to turn this conference over to Andrea Amadeo. You may begin.
Thank you. Hello, everyone. Welcome to the August 2015 TeamSTEPPS webinar on implementing TeamSTEPPS in a high acuity environment. It's a multifaceted approach in MetroHealth Emergency Department. If you have participated in our webinar series in the past, hopefully you quickly recognize that mine is not the voice of your usual host, Chris Hund. My name is Andrea Amadeo. I work for Impact International, which is part of the National Implementation of TeamSTEPPS team. And I have the pleasure of being a part of today's event while Chris is traveling to visit our TeamSTEPPS Regional Training Center in Seattle, Washington. So before I turn the presentation over to our speakers for today, I have a few slides to cover with all of you, beginning with a few logistics. There are two ways to listen to the audio for today's event. One way is through your telephone, and one way is through the speakers on your computer. If you're called in through your telephone, please look for the bright green speaker icon at the top of your browser window. There's an arrow next to that you'll want to select and choose Mute My Speakers. This will help us prevent any audio feedback. The second logistical item is about our question and answer session. So we plan to leave time at the end of today's presentation to answer some of your questions. The way to submit your questions is through the chat function on the right-hand side of your browser window. You can submit your questions at any time during the event. We're going to save them till the end, and we'll get through as many as we can during the live event today. Any that we don't get to, we will answer, and we'll post those responses with the rest of the webinar materials on the TeamSTEPPS portal. So I want to take a minute to acknowledge our project sponsors and project team. The National Implementation of TeamSTEPPS program is funded by the Agency for Healthcare Research and Quality, or AHRQ, AHRQ. Our task order officer, Dr. Jim Battles, and his Department of Defense colleague, Ms. Heidi King, have been longtime supporters of TeamSTEPPS and in fact worked on the development of the TeamSTEPPS curriculum. This program is managed by the Health Research and Educational Trust, or HRET, which is the research arm of the American Hospital Association. Their team's led by Barb Edson and Chris Hund and supported by another of others at HRET. My team, Impact International, is led by Dr. David Baker, who has also been a critical part of TeamSTEPPS for many years. We often hear from our audience members on these webinars that you're not all very familiar with TeamSTEPPS or the Master Training Program. So we wanted to take a minute to go over a little bit about what the Master Training Program is. This is a 2-day in-person course. It's based on a train-the-trainer model. So first, we expect master trainers to come to the course and learn the TeamSTEPPS tools and strategies. But not only that, we also teach you how to teach those tools and strategies to others. That's the first day of the course. The second day of the course is really about empowering you to be change agents when you get back to your organization. So this is a program where you're not just going to come to training and learn something and never do anything with it, but rather we really want you to feel that you have the skills and knowledge to go back and make change happen. And so some of the things we teach in the program are how to manage change, how to plan your TeamSTEPPS implementation, and also how to measure whether or not it's effective. We are actually coming up on the end of our current fiscal year, so we have one more webinar scheduled in September. On September 9th, we have the pleasure of hearing from Dr. Gerald Hickson from the Vanderbilt University Medical Center. He's going to be presenting about how to address behaviors that undermine a culture of safety, reliability, and accountability. And you can register for that event at the TeamSTEPPSportal.org. Because we're coming up on the end of our fiscal year, future webinar dates have not yet been planned, but we will be planning those in the next several weeks and sharing those with all of you soon. AHRQ also sponsors another program that offers master training. It's an online program, and we've provided the link to that course here in case you'd like to learn more information. This is great for people who can't travel to one of our in-person courses or just really need the flexibility of having as much time to do the course on their own time as they need. So please check that link out if you're interested in that option. And then we know that whether you're a newcomer to TeamSTEPPS or someone that's been working in the program for many years, you are bound to come across questions or challenges that you might need some help with. They might be questions about the training that's available, about the materials, or if you do encounter a challenge and don't know how to overcome it and suspect that others have, we can also help with that. So the helpline number and the email address on the slide here are a great way to reach out to the team here and learn about anything that you need additional help with. If it's something we can answer, we will certainly find a way to get the answer for you. So it's really my pleasure to get to introduce today's presenters, who are our colleagues at MetroHealth. I'd like to take a minute to share sort of my own and my team's experiences with this group. My team lead, Dr. David Baker, and I actually first met members of the MetroHealth team when they were attending a master training course at UCLA, which is one of our regional training centers, in August of 2013. A year ago, last August 2014, we had the opportunity to go visit MetroHealth and learn more about their work with TeamSTEPPS, and our experience there was extremely one that left us very impressed. So first of all, this is a group that has done an incredible job of establishing an infrastructure to support TeamSTEPPS at an organizational level. And in fact, Dr. Bob Smith, who's one of our presenters today, did a presentation about this earlier this year in February. And if you're interested in learning more about that, I highly encourage you to go to the TeamSTEPPS portal and check out his webinar from February. The second thing that was really impressive about MetroHealth's work is that this is a group that's really recognized and embraced the idea that TeamSTEPPS is not a one-size-fits-all solution. So they really take a thoughtful approach to working with each unit or work area and assessing whether or not they're even ready for a change. And then once they get them ready, they really work closely with that group to make sure that the TeamSTEPPS intervention that they select and move forward with is one that really addresses whatever specific teamwork challenge or issue that unit or work area faces. And now, like I mentioned, we visited them a year ago, and even a year ago, we could have selected any number of projects that they were doing that we would have loved for them to share with you on an event like today's. We thought that the emergency department implementation story they're going to speak to today was really important because it's one of their earliest TeamSTEPPS interventions, and it's been sustained for a few years. And we think that that's a challenge that a lot of our audience members tend to face is not just getting an intervention going, but how to keep it going. And Dr. Noeller is going to highlight some of the things that they've done to really sustain this, keep it visible, and I think also keep the staff really engaged. So with that, it's my pleasure to introduce our two speakers. Dr. Noeller is an associate professor at Case Western Reserve University School of Medicine. He's also the director of MetroHealth Simulation Center, and he's an attending physician in their emergency department. Dr. Robert Smith is the director of the Medical Staff Assistance Program at MetroHealth. He's also the director of their work as one of our TeamSTEPPS regional training centers. So with that, gentlemen, I will turn the floor over to you.
Well, thank you, Andrea. That was very, very kind of you to share the background for MetroHealth. On behalf of MetroHealth Medical Center, I want to thank AHRQ and HRET for giving us this opportunity. Dr. Noeller and I are pleased to be able to share our story. I'm going to lay some of the background, and so I'm going to talk a little bit about who is MetroHealth and how do we get TeamSTEPPS started, and then Dr. Noeller will talk specifically about the emergency department. So beginning with who is MetroHealth, well, we're a well-established healthcare organization. We've been in Cuyahoga County since 1837, so that's 178 years. We're one of the largest healthcare organizations with 700 beds and 17 community health centers. With regard to our medical staff, we have over 475 primary care and specialty physicians, over 1,200 registered nurses, and approximately 145 advanced practice nurses. When you take a look at the care that we provide, in 2014, at our healthcare center, we provided 28,000 patients care, and we delivered 2,900 newborns. In our ambulatory care centers, there were over 1 million visits, and in our emergency department, there were over 100,000 visits. MetroHealth is affiliated with Case Western Reserve University School of Medicine. So we're an academic institution. We have 24 residency programs, 15 fellowship programs, and we provide training for over 1,000 students from the medical school, nursing program, and other allied health programs. So that's who we are as an organization. In 2013, TeamSTEPPS came into view and was something that we began considering as a way of addressing low employee morale and as a way to improve patient care and patient safety. We established a steering committee and a change team. We worked very aggressively with our administration and our medical executive committee, ensuring that we had their support right from the start. After a lot of deliberation, we decided that we would do it system-wide so that we would include not just our clinical staff, but also our non-clinical staff. And we very much embraced the train-the-trainer model, and so we began training our master trainers. To give you an idea of our organizational change team, again, because we were looking at it system-wide, we wanted to include all of the primary clinical areas, but what you'll notice is we also included organizational development, our simulation center, communication, diversity and inclusion, marketing, and we have a fairly significant union as well. One of the ways that the leadership showed their support of our initiative was that we were revising our mission statement and our values. And so as we sat with them and talked about our mission, we were able to incorporate teamwork so that now it reads, leading the way to a healthier you and a healthier community through service, teaching, discovery, and teamwork. We established what we call STAR IQ values: service to others, teamwork, accountability, respect, inclusion, diversity, and quest for excellence. Our intent was to definitely avoid this becoming a training program. We did not want TeamSTEPPS to be viewed as another sort of flavor of the month quality initiative where we train a lot of people and then it goes away. We wanted to make sure that it became part of our culture. And so by incorporating it into our mission and our values, we felt that we had more of a foothold. So having put everything in place to form a foundation, in 2014 we began our implementation. Again, what you'll notice is we focused on some key departments, but we also focused on our administration, and again, to ensure that they became perhaps not master trainers, but at least coaches who understood the principles and the strategies related to TeamSTEPPS, and that they could support those departments who were moving forward. This year we've continued. We've added additional clinical areas, and we're at about 40% of our total staff. So we have about 6,500 employees, and as we move forward, we're looking at about another 1,500 to 2,000 this year. Again, focusing on clinical, but again, you'll see the non-clinical areas: finance, information system, environmental services, dietary, textiles. Our goal is to help everyone have a common language and system and approach to solving problems so that everyone understands the concepts related to TeamSTEPPS. So now I'm going to turn it over to Dr. Noeller, who's going to talk specifically about our emergency department.
Thank you, Bob. It's really an honor for me to be able to participate in this, and thank you all who have tuned in. So hopefully we can share some ideas even in the Q&A afterward, and allow us to share some of our experiences here at MetroHealth. Metro's emergency department is a busy place, and I think probably at least some of you who have tuned in today are at busy emergency departments as well. But even if you're not, a lot of the lessons that we've learned in the implementation of TeamSTEPPS are widely applicable, regardless of whether you're in a small community emergency department, whether you're in an emergency department at all, or even in the largest, busiest places in the country. Our ED is an urban, academic, and community emergency department. We really serve the community of Northeast Ohio, and we're an academic environment as well. We have, as Bob mentioned, over 106,000 patient visits annually, a large staff, and an active residency program, 13 residents a year, and we're affiliated with both Case Western Reserve and Cleveland Clinic. Our nurses are top-notch, and I think that's one of the keys to the success of TeamSTEPPS here is a top-notch staff really throughout the organization. They've achieved magnet designation, and really through, I think, the teamwork that we've all displayed together has helped that along. Metro Lifelight is a nationally recognized air medical program that services the entire region and services our level 1 trauma and burn centers. We also serve as a receiving center for high acuity patients really from all over the region with stroke and STEMI, for instance. We really view the ED team as not only the team within our walls, but everybody who interacts in the emergency department. All of you work in an emergency department really understand the analogy that the emergency department is really the grand central station of the hospital. There's lots of comings and goings and lots of folks that interact in that one place at one time or another. At the core of the team, of course, are our patients. And everybody else who you see listed here are part of the team at least at one point or another. All the way through those that you see listed here from the beginning, all the way down to the end of the list where we include other departments and other hospitals since we receive patients from other places. And really, so we have to think broadly about any implementation of TeamSTEPPS to include all of these individuals, really to incorporate the entire MetroHealth system and the Northeast Ohio healthcare community. So when taking on a project that involves introducing a program like TeamSTEPPS and to effect a true culture change, you have to start at someplace. And we're pretty practically minded in the emergency department. We like to get things done. We like to see problems and fix them. And we applied that mentality to the implementation of TeamSTEPPS. It's a large program with lots of facets, and as was mentioned earlier, can be adapted to an array of situations. To get things started with us, we identified certain targets. And a lot of the targets you see here, and I've listed only a few that we've tackled over the last couple of years. Our trauma resuscitations require a coordinated team response. Being an academic institution and a level 1 trauma center, our trauma activations involve an array of disciplines and specialties all coming together at one time that need to coordinate a response. And whether you work at a trauma center or not, you can see analogies that might apply to cardiac arrest or someone in respiratory distress, or really an array of situations that require a multidisciplinary team coordinated response. We saw a need to help patients who required escalating levels of care even while in the emergency department. Sometimes patients who come in very sick get care immediately. We know if somebody who comes in by EMS has respiratory distress, a team will meet that patient at the door and render care immediately. Sometimes a patient gets sicker while in the emergency department, and it can be a challenge sometimes to get the same level of resources to the bedside during a long ED stay. I may have nurses that are being pulled to traumas or transporting patients upstairs or caring for patients in other rooms, and if I need resources at the bedside for a patient who's getting sicker, we saw a need to coordinate the same level of response that we coordinate when a patient first arrives. And this escalating response scenario was a target for us. MetroHealth recently became an Ebola treatment center designated by the Department of Health, and this was a new experience for us and required a coordinated team response as well as a perfect application of the TeamSTEPPS principles. I think if you work in any emergency department, really any healthcare environment, you understand the importance of transitions and handoffs and what a high-risk time that is, and what a ripe area to apply TeamSTEPPS principles that is. Throughput is a universal problem in emergency departments and in hospitals throughout the country. Again, a perfect area to apply TeamSTEPPS principles of situation awareness and communication. And then the target of overall team culture, building this up, becoming part of the culture and sustaining this for the long term. These were our targets. To address the targets, we then turned to TeamSTEPPS. What elements of TeamSTEPPS could we possibly apply to help us fix certain problems or address some of these targets? And you see them listed here. Now, frankly, you could incorporate all of the elements of TeamSTEPPS with each one of these targets. However, we chose certain elements to focus on so that we could more easily address them and more efficiently address them. So how do we get started? Well, the emergency department presents certain challenges, as we all know, in schedules and coordinating people to work together and to train together. It's a 24/7 operation, and people have 24/7 schedules and weekends and holidays, and trying to get everybody together at one time is essentially impossible. How do we start the training program, and how did we make it relevant to what we do? Well, the key is, first of all, making it mean something. Tapping into the mentality of the emergency department, that problem-oriented, solution-oriented approach was key in the beginning. We went to people in the emergency department and said, what are some of the problems? What are some of the issues that we could possibly address? Well, that's where we started, and that's where we came up with our targets. We made it relevant so that people could come to TeamSTEPPS and say, hey, this is going to help me do my job and help me take care of my patients. And as Bob mentioned earlier, we had to make it very clear from the beginning to this sometimes cynical bunch in the emergency department that this is not just another flavor of the month training program. Oh, great, we get to go and spend another couple of hours in a conference room and walk away feeling good for a little while, but how is that really going to impact my care? We had to make it very clear from the beginning that this is a culture change, that this is something that's really going to help us take care of our patients and help us do our jobs better. The plan. This is how we did it. First, TeamSTEPPS, while some of the teamwork concepts were familiar to people, the TeamSTEPPS structure, the content was not. So necessarily there is some didactic element to the training. To do that, I'll talk a little bit more in a few minutes about the nuts and bolts of how we did that, but we presented a couple of options to people, both a live didactic program and an LMS version that they could access on their own time. Beyond the true knowledge acquisition, we then recognize that adult learners learn by doing. In my role as director of the Simulation Center here, we see this every day. People can learn things in a classroom, but not really know how to use them until they apply them. Simulation gave us an outstanding avenue to train people and show them how TeamSTEPPS principles can be applied in realistic settings. And then to effect real change, we had to give people tools. It's not enough to simply know the material. Even to apply the material in a simulated setting, you have to have the tools to apply them in a real setting. And in a dynamic, high acuity environment like the emergency department, making these efficient, easily accessible tools was really important. And then to sustain it, this is a constant challenge, I think, no matter where you are. You have to build a team to help sustain it. We have to build in elements such as training for our new hires and retraining for people who have been here for a while to constantly refresh and renew the energy that surrounded the implementation in the beginning. The new knowledge acquisition phase, in more detail here, we offered both a live didactic presentation, which was a 45-minute presentation that I put on for our team. We scheduled it, of course, at multiple points throughout a day. We scheduled, I believe, 8 sessions over the course of a couple of months at 7 a.m., shift changes, 3 p.m., 11 p.m., and at various points of the schedule so that we could capture as many people as we could. We got buy-in from our leadership in the beginning. They understood the importance of this. They had heard about it, and they had actually gone through a little mini training session ahead of time and understood the importance. So we got buy-in from our leadership to commit the staff hours to the training, and this was an important part of things. The training actually supplanted some of the other training that folks had already allocated time for. They saw the importance of teamwork training and sent people to this teamwork training perhaps instead of other training that they may have gotten. So we got the commitment early on. For those who couldn't attend one of the live sessions, we offered the LMS session where people had to sign in with their password, of course, and their own schedule, their own time. But we constructed it in a certain way that there was an audio narration of the slides that they had to listen to before clicking to the next slide. The advance arrow didn't come up until we were done talking about the slide. So they had to actually listen to it. They couldn't just click on it and then make their dinner. And then at the end, there was a test. So those who took the LMS had to do a couple of additional steps that those who didn't attend the live didactic had to do. But we assured that they listened to the presentation and got something out of it. Now, the TeamSTEPPS videos are great, but we took it one step further. We actually customized and made a video of our own incorporating the TeamSTEPPS principles. One of our staff members actually has a background in production and gathered some of the thought leaders, some of the folks that were respected in our department, and recruited them to be on a video. We used a Star Wars theme, and if you can picture this, there was we created the Thought Leader Council of Elders, and they were sitting at a table in front of a young Jedi resident who came up and asked about the ways of teamwork in the emergency department. And they role-played a little bit of the Star Wars characters while this Jedi was escorted through a montage of videos of various teamwork aspects in the emergency department. It was entertaining. It showed that the people who were respected in the emergency department bought in to TeamSTEPPS and showed that it was an important part of what we intend to do. So between the didactic, the LMS version, the Learning Management System video version, and our customized video, we were able to impart the knowledge of TeamSTEPPS to all of our staff members in the emergency department. But as I mentioned, that wasn't enough. So they know the concepts, but now they had to put them into action. So everybody who was in the emergency department and completed their didactic portion then had to sign up for a high-fidelity simulation. Our simulation center had just recently opened at the time, and we created a couple of scenarios whose objectives and goals were geared all at TeamSTEPPS. We sort of de-emphasized the clinical nature, the medicine of this, and emphasized the teamwork aspects. There were critical actions and objectives targeted at each one of the domains, and we used real scenarios with a real team and a real environment. You can see the picture on the slide here, and this is a real simulation. You can see that there's a medic, a nurse, and a couple of physicians all participating together and training together. Before this really didn't happen all that often, if at all. To get everybody in the same room training together on these concepts resulted in what you see on the bottom line is, I heard it over and over again, now I get it. They can understand the concepts, but until they put them into action, they really didn't understand. But they walked away from that simulation afterward really truly understanding the TeamSTEPPS concepts. The next step is real implementation. So I'm going to walk through a few examples of some of the tools that we implemented in the emergency department following the initial wave of introduction of the concepts through the simulations and the didactics. As you recall, our first target was our trauma resuscitations. Our trauma resuscitations run well. They ran well at the time, but there's always room for improvement. We're a level 1 trauma center that incorporates multiple specialties, multiple disciplines, all coming to the bedside at one moment to take care of a high acuity patient. There's always challenges in that. Who's leading the resuscitation? Who's doing what? Who's responsible for what? What needs to be done for the patient now and before they leave the room? And how do we make sure that this is done reliably and effectively every time to achieve the level of quality and efficiency that we need? Well, we took lessons from TeamSTEPPS, we took lessons from other organizations and other, not only in healthcare but outside of healthcare, and came up with a few different tools. One is an example that you see on the slide is our pre-departure huddle. That, in conjunction with the pre-arrival brief checklist, allowed our team to get together to make sure that all of the necessary elements of care were administered to the patient. The brief brought in elements of team structure and leadership. Who's the leader? Who's doing what? Who's on the right side of the patient, the left side of the patient? Who's got airway? Do we have all the necessary equipment? Have we communicated the goals and objectives of care? And what's our plan? The huddle checklist that you see here assures that all the things that are necessary for the care of the patient are completed. Now, these tend to be things that we may not have remembered routinely beforehand, but make sure that we remember now. These green sheets, we call them, are incorporated into the trauma pack that's pulled out before the patient even arrives. And is the physician in charge of the resuscitation is responsible for completing this by completing a brief and a huddle at the appropriate points of the resuscitation. Initially, when we rolled this out, we had a QA process in place to give feedback to all of the physicians who are running resuscitations. They're responsible for putting their name at the bottom of this quality assurance document that's not actually incorporated into the chart. It's used as a QA tool. We had a QA specialist logging all of these and would tally these at the end of a month and give feedback to the providers. For instance, hey, doc, you ran 50 resuscitations last month. You completed green sheets on 32 patients. And then we would plot that data against other providers in the department. They would see how they perform. And, of course, measuring against your peers, people would want to make sure that they've completed these to a high level. In addition to these checklists, we made some changes in our configuration of our rooms. And this is done in a lot of trauma centers. We didn't have this ahead of time. We configured our room in such a way where we painted a red line around the bed. This helped designate who was on the team and who is responsible for care. If you're inside the red line, which is sort of analogous to the key in a basketball court, if you're inside that zone, you're taking care of the patient. If you're not taking care of the patient, you're out of the zone and you stay behind the red line. And the team leader is responsible for making sure that only those inside the line are taking care of the patient. And if you're not, then you're out. And this is a key element of all of this is continuing education and orientation. We have a constantly cycling group of residents and interns, and even a little turnover in staff, as every place does. So a constant education and orientation to this process is a necessary element of this. In regards to our escalating response, as I mentioned a bit earlier, there are times where patients need escalating levels of care in the emergency department. We struggle with this a little bit. I know some other places struggle with it even more, is that patients can spend some time in the emergency department while waiting for an ICU bed or a step-down bed somewhere in the hospital. At times, patients who come in and are initially stabilized may then get a little bit worse, say the septic patient who needs more resuscitation, or the patient in respiratory distress who may have a little bit of a waxing and waning course. That initial response when the patient gets there is pretty dramatic sometimes, but then once the patient stabilizes, people tend to disperse. If I then recognize that the patient's getting sicker, or what's key to this is that any member of the team who recognizes that the patient is getting sicker can call for help. And the way that they call for help now in a coordinated response is by using the code STAR response that we've developed as a result of TeamSTEPPS. The code STAR stands for Situational Team Assessment and Response, and team is right there in there. Anybody who sees that the patient is deteriorating or who needs a coordinated response and is not immediately available can call a code STAR. It goes out over our pager system just like any other code, and there's a designated response by additional physicians, nurses, paramedics, and radiology to all descend on the patient's bedside. We conduct a brief and a huddle and reestablish goals of care, necessary resources, and address elements of leadership and team structure, all in an effort to improve situation awareness and facilitate a communication at the patient's bedside to get the right resources to that patient at the right time. As I mentioned, Metro was designated recently as an Ebola treatment center by the Department of Health. We're at the time the only one in the state, and this was not an easy process in the beginning. It was a new process for all of us. To start down the road of responding to a patient who might present with signs or symptoms of Ebola, and we did actually at one point have a patient who presented with symptoms that needed to be addressed. We had to have a coordinated team response, and this was a new process altogether. We started the process by conducting simulations. We actually brought a simulated patient, to the front desk of the emergency department and ran a simulated response, and we learned a lot. About 10 or 15 minutes into the response, we recognized that with multiple teams and multiple disciplines descending on the emergency department, from infection control to police to EVS, environmental services, and nursing and physicians from different disciplines, we're all trying to coordinate a response to this patient during the simulation, and immediately we recognized there's a real need here for a coordinated team leader, situation leader, some team structure, some situation monitoring that wasn't occurring, and some efficient communication that needed to occur in a much more efficient fashion. And those of us who had had our TeamSTEPPS training at the time looked at each other and said, hey, this is a great time for TeamSTEPPS. So we took a step back after the simulation, and in the debriefing, adapted the team performance observation tool to Ebola. And you can see an example of the first page of that up on the slide and how we adapted it specifically to that response. It's worked wonderfully. And as we've conducted other simulations, and in fact one is occurring again tomorrow, we're adapting the principles over and over and over again to the point now where the folks who initially responded are now coming to us and saying, hey, how about some of that TeamSTEPPS stuff? Shouldn't we incorporate some of that here? And it's a very nice response, and we're seeing that more and more as we adapt these tools to different protocols and processes. As everybody knows who's listening, I assume, transitions and handoffs are a high-risk time. Because communication is so critical, we recognize that all the instances of handoffs and transitions that occur in the emergency department, from shift changes to admissions to sign-offs, transitioning a patient from one part of the ED to another, all of these are high-risk times where critical elements can be missed if not handled efficiently. Rather than taking on the entire project, and this is a theme that I'm emphasizing over and over and over again, we took one bite. We tackled one part of the problem to get started. And the part of the problem that we addressed here was the issue of admitting critical patients to the ICU. Hopefully, ICU patients who are admitted to the ICU from the emergency department, they may come into the emergency department fairly sick, but by the time they're admitted, we hopefully have them stabilized and much better. So they may not need an ICU from the time that we initially admit them to the time they actually go upstairs, because that time can be sometimes a couple of hours. We've instituted a pre-departure assessment, where it's essentially a huddle at the bedside. When a patient is admitted to an ICU, the nurse is empowered to call a physician to the bedside after performing a pre-departure assessment if he or she sees something that is different than when report was called a couple of hours ago. So, for instance, the patient is septic, they're intubated, they have fluids hanging, they have pressors hanging, but now, the patient's blood pressure is stabilized, their heart rate's better, they seem to be perfusing better, their mental status is improving. Maybe we can wean off the pressors. If they're not intubated, maybe they can go to a step-down unit instead of the ICU, for instance. So this pre-departure assessment assures that there's an ongoing assessment of the patient even prior to going to the ICU, so frankly there's no surprises when they get upstairs. Maybe we can de-escalate the level of care. Maybe on the opposite side, they're getting sicker. Maybe there's something that was unrecognized, and they now need to be reassessed and maybe have an escalation in their level of care. The whole idea is to promote communication, situation awareness, and empower the people at the bedside to let the rest of the team know that there's been a change. Throughput is a universal issue. Huge problem, again, that we've decided to tackle in very specific ways using TeamSTEPPS. We know, as everybody should at this point, that throughput is not just an ED problem. It's a system-wide, hospital-based problem. When patients are upstairs for long periods of time, when tests aren't ordered in a timely fashion, or if consults are ordered late in the day instead of early in the day, for instance, things can get backed up all the way down through the emergency department. Communication from the ED to the upstairs and upstairs down to the ED is critically important so that everybody maintains the situational awareness that's necessary to optimize throughput. To do this, to help solve this problem, we've instituted a regular huddle schedule where the ED attending, the charge nurse, and a physician in charge, the PIC from upstairs, comes to the emergency department, and we huddle together. We look at pending discharges and admissions, assess the level of care that's necessary for all of the patients on the board, and try to determine if we can somehow make adjustments so that we can optimize the efficiency of the whole throughput process. This is, aside from the regular huddle schedule, this is an active polling process. Rather than us pushing patients upstairs by admitting and then waiting for the beds to be ready, the folks upstairs are coming to us and actively pulling the patients up. So the PIC will come down, the physician in charge will come down, look at our patients with us, and say, you know what, if you just repeat that potassium on the patient, it was 2.5 before, and you get it now into 3, I can put them into a floor bed instead of a tele bed. And we can have an active discussion promoting, again, situation awareness and communication to help make this a very active process and move patients through the system to get the care that they need. Now, as we start to talk a bit about sustainability, the team culture overall is incredibly important. Each one of the elements that I've talked about, each one of these projects, each one of these problems and solutions is really important to give people a focus for their teamwork efforts. But the underlying culture change has to be part of this on an everyday basis, not just on a project-oriented basis. To do this, we've created a Caught in the Act program. Now, this might sound a little sketchy at first, but the idea is that we've recruited some secret shoppers, so to speak, in the emergency department. We have folks that are TeamSTEPPS converts through and through that are constantly on the prowl for acts of teamwork in the emergency department. When they spot somebody who has displayed excellent situational monitoring, who has been a great team leader, who has provided mutual support to one of their colleagues, they secretly report that back to me, and then we publicize that. We go to the individual who is caught in the act. We call them into their director's office or their chair's office, which generally can be, might be thought of as a bad thing, but in this instance is actually very good. You get called to your boss's office, and you're told, hey, guess what? You've been caught in the act. And then a description of their act is given to them. And if you look at the slide on the board here, there's a picture of our latest person who was caught in the act with a description above his head of what he was caught in the act for. And this goes up, this board sits right outside of our emergency department, right by the time clock, so everybody who comes in every day sees that. In addition, they get a T-shirt which says MetroHealth ED Team, and they can wear that T-shirt on shift. They have a coffee mug that says exactly the same thing. It says Teaming Up for Patient Care, and people love this. It's a recognition of good teamwork, and it shows that the department values good teamwork and the implementation of the TeamSTEPPS concepts. In addition to that, to help promote this culture of good teamwork, we've instituted a Walk a Mile program. It's a cross-disciplinary shadowing program, and primarily is so far instituted with our new residents who have come in. They spend a shift shadowing the ED charge nurse, shadowing the medic, performing EKGs, doing IVs, and being up in triage. There's no way better to really appreciate your colleagues' work and to understand all of the elements of the team unless you actually walk a mile in their shoes. And this program has been widely accepted, widely valued, and people just love it. The other parts of sustainability are critically important here. The TeamSTEPPS Action Council that we've instituted throughout all the departments in the hospital, and specifically here in the emergency department, is a multidisciplinary team. It's a frontline personnel that see the issues, see the problems every day. What's important is that they're empowered to actually do something about it through the TAC. We have the backing of the TeamSTEPPS organizations throughout the hospital and Dr. Smith. We have the backing of the nursing administration and our chair. So they come to the TeamSTEPPS Action Council with ideas knowing that they're actually going to get something out of them. We have specific goals and objectives that we set out for ourselves. And we meet just before the Ops Committee meets, once a month. So our council meets, discusses some issues, comes up with very concrete solutions, and then presents them to the Ops Committee where we get backing and where things can actually occur, where change can actually occur. There are many achievements, some of which I've listed here. Code STAR that I mentioned earlier came out of our TAC. We've made some improvements in our care of our psychiatric patients who can tend to spend some time in the emergency department, and in our registration of our trauma patients to make that a much more efficient process based on the input of the folks who do the registration. And without their input on the TAC, I'm not sure their voices would have been heard as effectively. And the key elements of sustainability, finally, in addition to what I mentioned already, are these elements here. You have to tackle the new hires. You have to have a constant plan for people coming into the organization to tell them that, hey, TeamSTEPPS is part of your culture here. If you're being hired here, this is what the expectation is. And Dr. Smith and others among our master trainers have instituted a TeamSTEPPS orientation program as part of the hospital orientation for all new hires, no matter your discipline. In the emergency department, we provide refreshers. And we're in the midst of starting another refresher phase right now for all of the folks. Even if you've gone through it before a couple of years ago, you get to go through it again. Let's keep it fresh. Let's keep it in the forefront of everybody's mind and give new ideas all the time on how to implement it in our department. And finally, you can't do this alone. If you're sitting there right now listening to this webinar thinking, how am I going to implement these things? Or, hey, I've done a couple of these things, but how do I do others? You can't do it alone. Recruit others. Get other instructors to help you. Build your own team and delegate tasks and create your structure, create the leadership, provide your own mutual support and your own situation awareness to your own implementation team. Recruit other instructors and even some master trainers to help you do this because you can't do it alone. And that concludes my portion of the talk. I'll turn it back over to Andrea to handle any questions that we may have.
Great. Thank you both so much. That was an excellent presentation. And not surprisingly, we received a lot of questions while you were talking. So we'll try to tackle a few of them in our remaining time together. One of the sets of higher level questions that came in were about time commitment for training. So you talked about training new hires and also getting staff on board with TeamSTEPPS for the first time and then following up with these refreshers. Can you give the audience a sense for the time they would need to set aside for those activities?
Well, specifically for the emergency department, I'll take it sort of step by step. Our residents have a set-aside time every week, 5 hours of didactic time for their schedule. What we do is we pull some of that time into TeamSTEPPS. So instead of sitting in a lecture or something else, we pull them in for simulation or for the didactic. As part of our intern orientation recently, they all went through TeamSTEPPS on a hospital level and with simulation and with the didactic portion, with the emergency department version of our didactic portion. So there's several ways that we brought our residents into it. As I mentioned earlier, we got a lot of buy-in from nursing administration, from the management and directors. So every year there's a budget set aside for education and training for the nursing staff. And when we discussed with the nursing leadership the importance of teamwork, this resonated. We didn't have to sell this at all. I mean, this is part of the culture here at Metro. It's part of the magnet designation. There are lots of drivers that tell us that teamwork is important, so we really didn't have to sell it. They simply took some of the time that they were using for other things and brought people in to do training on TeamSTEPPS versus something else.
Andrew, on a hospital level, the way that we approached it is that we basically determined what it would cost if everyone went through training and gave a figure to our executive council and the medical executive committee. To offset that, what we did is we talked about what the cost was in terms of malpractice suits that occurred in the last 5 years. What we were able to demonstrate is that 60% of the malpractice suits that occurred were the direct result of a breakdown in communication and teamwork. Thus, if we were able to implement TeamSTEPPS effectively, improve patient safety and patient outcomes, we would avoid future malpractice suits. And so that seemed to be very convincing to the administration.
Great. Yeah, that's really helpful. Were there any unique challenges with getting participation or time commitment for the simulation side of the training?
It's a challenge always to get people to sign up for any training. So we didn't make it voluntary; it was mandatory, and that came again from the nursing administration. So getting that initial buy-in was really important. Frankly, I think any of us who've done any training at all understand that there's usually the first adopters, the first wave of excited people to sign up. Then there's sort of that moderate group that just needs a little nudge, who really wants to do it, who just hasn't had the opportunity to sign up. And then there's the reluctant, quarter or a third of people that really need a nudge. And that's the way we approached it. We put up sign-up lists and provided the opportunities, opened up the Sim Center, got our residents out of conference, and then everybody else signed up to participate as a team. Once word got out, after the first few, there was a rush that we didn't have to recruit people at all. They loved the idea of simulation. Everybody who came in here said, boy, this is how we should be doing our training all the time. So much more powerful to get hands-on and work together. And, man, it's great hearing what the docs have to say about how resuscitations are run. And the docs were saying, well, how great it is to hear the nurse's perspective. So once word got out, it kind of took on a head of steam, and we really didn't have too much trouble at all. The logistics, and the time commitment really got back to what Bob said and what I said earlier about allocating the time and paying people to be here, of course. And they had the budget for that existing, and again, it just supplanted other opportunities for training in other areas.
Great, thank you. Gosh, there's so many good questions, it's hard to choose, but a few are coming in about a topic that I think is important, which is how are you assessing through any type of measurement whether this is working?
So the way that we're assessing things over time are, when we did the QA measure of completion of the trauma sheets, we had a QA process in place just to see that people were actually using them. That's just a surrogate measure of effectiveness, and then anecdotal evidence, what people are telling us, and hey, I had a patient the other day who, if we didn't do the checklist, they wouldn't have had their X-rays looked at, or we would have missed this problem. Right now, currently, we're in the process of conducting a couple of research projects. One that has to do with, as you can imagine, the initial phase of the first couple of years of implementation is just getting people to do these things and seeing that the sheets are being done. Now we're looking at investigations on what sort of impact it has in real patient care. So a couple of research projects that are in the stages of starting right now are, one, what sort of things are we catching using these checklists that we would have missed otherwise? And so we're doing a study like that very soon right now, and I actually have medical student observers that we've gotten from the medical school who stand in the trauma bay and observe the teamwork behaviors and observe the completion of the sheets and observe things that were caught by the checklist that maybe wouldn't have been caught without the checklist. So these are research projects that are ongoing right now. In addition, one of the measures that we want to look at are nursing retention rates. Now, this is a multifactorial process. We think that a culture of teamwork and openness and empowerment and education and participation in multidisciplinary training will result in improved nursing retention, and that's the subject also of a research project right now.
To add to that, Andrea, our surgical intensive care unit has been using a variation of the AHRQ survey, and they did a pre and a post. So what they were looking at was patient safety, communication, and job satisfaction. And fitting with what Tom just said, they used an intervention modifying their rounding process, which greatly empowers the nursing staff and gives them a new role. And what they found was that the post-test showed a significant increase in job satisfaction, particularly for the nurses, which again I think can lead to better retention.
That's great. Those are all good ideas for thinking about measurement. One other question that caught my eye earlier is when we think about doing training or simulation, how can we address those cases that aren't short-term, but where a patient is likely to be in the emergency department for a longer period of time or across multiple shifts? How can we use TeamSTEPPS or training opportunities to improve communication and coordination in those situations?
Well, specifically, when you do simulations, there are ways in simulations that you can time-lapse things. You can do episodic care. Simulated over, 4 hours of care can be condensed down in a simulation to 20 minutes if you just capture sort of in a still frame fashion various aspects of the care, the transitions, for instance. So you can start a simulation with the patient's arrival and then wind it down and then ramp it back up when there's a change in the patient condition and somebody calls a code star, for instance. Then execute the code star in the situation, then things die down a little bit, then you restart the simulation when the transition happens to the floor and the nurse does the pre-ICU admission assessment. So you can capture the critical times during a long ED course without necessarily having it take the entire real time that it might take otherwise.
Great. And since you had mentioned the STAR code, I'll sneak in one final question, which is, could you speak briefly about whether this is unique to the emergency department and whether it's different from a rapid response code?
Yeah, and we took the idea from rapid response, and every hospital, a lot of hospitals have a rapid response team. We sort of view the emergency department as a continual rapid response environment. And the challenge that we face was that because there's always a rapid response in room 1 and 47 and 18, something's always going on, that we had to address the idea of there being sort of a rapid response fatigue in the emergency department. So the initial challenge we had was, well, geez, everything we do is rapid response. Why do we need this code star? So we adapted it a little bit differently for the emergency department to elevate it to the level of a trauma response or a code response that we would get to otherwise. So a little bit different than that. This is a full-scale, multidisciplinary bedside from all the different disciplines, from radiology to nursing to paramedics to physicians, all descend on the bedside. And it's not only the response, it's the elements of TeamSTEPPS such as the brief and the huddle and the leadership and the team structure. All of that comes into play. And there are defined periods of time where we can de-escalate and based on the patient's response and the set of criteria that we use. So it takes sort of the rapid response idea a little bit further to address the initial concern that everybody had about the rapid response fatigue.
Great, thanks for clarifying that. Well, unfortunately, I see that we're at the top of the hour, so for those of you who asked questions that we didn't get to, we will do so and post those answers for you in the coming weeks. But with that, I'd like to extend a sincere thank you to Drs. Noeller and Smith. It was a great presentation, and we look forward to continuing to work with you.
Thank you.
Thank you.
Thank you, everyone.
Thank you very much. Ladies and gentlemen, at this time, this conference is now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you.